So our next speaker, our next presenter is Dr. Edwin Lee. He's a good friend of mine. I'm going to try to introduce him without reading this. I think I should be able to. Dr. Lee, he's a board-certified endocrinologist, focusing also on age management medicine, has a wellness practice in Orlando, Florida. He's the co-founder, alongside with me, of the Clinical Peptide Society. We've been doing this for a few years. He's also part of the board of the Age Management Medicine group. He lectures everywhere, does a lot of interesting things in his practice, does research, and we gave a peptide workshop yesterday. It was a full day, pretty intense. So I'll have him come over. His talk now is going to be really interesting. So, Dr. Lee. And he has a great sense of humor. So.
All right. Good morning, everyone. And just raise your hand if you guys use a lot of semaglutide. Just curious. It's hard to see. All right. So there are going to be people who are new to this. So, but I have other things that I will talk about to help with weight loss. So. My talk is weight loss without using stimulants. So we'll be talking about GLP-1, GIP, and a peptide that I use. So an overview is that we'll be talking some incretin peptides, semaglutide, tirzepatide. That's a hard one for me to pronounce. And some new ones, and MOTS-C. So this is what I hear all day long, is like, hey, when I was young, I was in great shape. In high school, I was just ripped, and I just played sports, and then I got married, and life got busy, and this is me 20 years plus. So just raise your hand if you see this, because I see this all day long. It's like, man, when I was young, I was really good shape. But, I don't know about Puerto Rico, but in the U.S., it's somehow around 20, everyone hits their peak, and then they go to college, and then it just starts falling apart. But in certain other countries, like around the world, it's reverse. Like like if you go to the Norwegian and Sweden and all that, the government actually pays them to exercise, to be active. And to me, I think that's a whole different mindset. I mean, that's something that I think we should be talking about this to people in government. It's like, hey, we have a health issue here. We should, everyone should be doing some type of activity, doing work, whether they play basketball or have them go to a gym or do some activity. Because anyway, if you go to other countries, you don't see the obesity as much as I see it in the United States. So that was a great talk by Elliot. So anyway, a lot of people have the fat gene, and Elliot elegantly mentioned several of those genes there, but I've been watching my father, who recently passed away, and at age 88, this guy could love to eat. He just loved to eat. That was the thing. And I'm kind of genetically cursed because I love to eat too. But if I exercise, I keep my weight down. But I do. If I don't exercise, I travel or something like that, I easily gain weight. So I have the fat gene. But epigenetics really can turn on those fat genes. So raise your hand if you know what this is. What's the diagnosis? Okay, and yes, you guys, it's acanthosis nigricans, and it's a sign of what? Insulin resistance, right. And so I was shocked. I was in the elevator in San Francisco with my kids, and we were like in the back of the elevator, and some young kids came, and these kids were like 5, 6 years old. They were overweight, but they had a short sleeve shirt, and you could see on the back of the neck, just like that, and their father was and parents were overweight. And it's like, oh my God, these kids are really, it doesn't look good for them because they have insulin resistance. And insulin resistance basically is like it's like really the godfather of all these diseases that's going to fall through. So all these chronic disease, early heart disease and stroke, and then eventually diabetes. So I think everyone has heard of insulin resistance, the precursor of diabetes. If you measure, I have patients coming in, they go, Doc, I can't lose weight. So we'll check a fasting insulin level. And if their fasting insulin levels like 8, 9, 10, double digits, I'll just circle that number and say, look, you will never, ever, ever lose weight with that number. You got to get that insulin level down to 3 or less. So that's one simple test you can do. They have to be fasting, because if they're not fasting, their insulin level will be up. So this is a marker that you can do in your practice on Monday, is check fasting insulin levels. And you'll be shocked on how high these people are. And then they'll say, oh, Doc, I don't know. I mean, I eat clean. I don't know what. They always say that. But when they lose their 20, 30 pounds, then the confession comes out. I forgot. I've got to tell you, I used to eat all these brownies, popcorn, and pretzels and all that. I forgot about that. But once they start losing weight, then the truth comes out. But initially, they're always resistant to confess. But anyway, if you have too much insulin, you're going to become fat. If you give an animal like a mouse or a rat, they know when to stop eating. But once you give them insulin, they can't stop eating. They just constantly eat, and they're going to get fat. So the thing is, higher levels of insulin is going to basically turn on those fat cells, and you're going to gain weight. So what is this? What is this? Lewis has a pet of this, because Lewis has some interesting pets when he was growing up, scorpions and tarantulas. Does anyone know what this is? It's a Gila monster. It's a poisonous lizard. There's like 2 poisonous lizards in the United States, and this is one of them. So they actually discovered basically the GLP through this lizard, because this lizard only eats like 2 or 3 times a year. So cold-blooded reptiles generally eat once a month, so they couldn't figure out why this cold-blooded reptile only eats 2 or 3 times a year. And it turns out they have high levels of GLP-1 in their saliva, and it's believed to turn off the lizard's appetite. So that's kind of how we stumbled on this field of GLP-1s. So GLP-1 is an incretin peptide hormone. So rather than, that insulin secreted from the beta cells from the pancreas, but we have hormones that are secreted from our small intestines. And GLP-1 basically gets stimulated once food is given. If you give glucose intravenously, GLP does not go up. It has to be through the oral route where GLP-1 goes up. As we age, what happens to our GLP-1 levels? Guess up or down? What do you think? It goes down. Yes, everything goes down when we age. So the thing is that it goes down, our weight goes up, also insulin level goes up, and it just is a downward spiral there. So if you increase these incretin hormones, it actually releases insulin, and it will help lower blood sugar. But some incretin hormones also secrete, actually decreases glucagon. So if you decrease glucagon, you can also help lower blood sugars there too. So GLP-1 has been revolutionary. I was very active when it first came out, and I just love it because this is the first time in the diabetes world you can give something that they can basically lose weight and lower blood sugars. I mean, it's a win-win situation. Before that, metformin basically was weight neutral, but once they get on insulin, it was like, it's over. They all gain weight. So this is me with Dr. John Eng. He discovered the GLP-1 from the lizard. He was a struggling endocrinologist, at the VA system. He tried to convince his wife, we have to put all our savings to patent this. And the wife thought he was crazy, but every month they would just put money just to get that patent, and he's making a killing now. But anyway, I keep telling my wife, we got to get a sailboat, but she says, I don't know what this means. Tell me what this means. You get a new boat, new wife. Does the new wife come with the new boat? I don't know what that means. Anyway, I don't think I'm going to get a boat ever, but it's good to have friends that have boats. But anyway, so this is Dr. John Eng in 2007 with me. So he basically discovered the GLP-1 hormone here. So here's a list of the once-a-week GLP-1 analogs. You have semaglutide. The commercial name is Ozempic. It used to be 1 milligram once a week, but for diabetes now, FDA approved it for 2 milligrams once a week. And then the semaglutide higher dose is Wegovy, which is 2.4 milligrams once a week, and that is FDA approved for weight loss. And then you have duglutide or Trulicity, which is 4.5 milligrams once a week. So this was nicknamed, I wish I thought of this. I've been like way ahead of, I have a wellness practice, and in a wellness practice, it's cash. I deal with no insurance at all. So you have to show your patient, you have to listen to them. You have to see what they want, but 90% of my patients that come in, they're tired and they're overweight and they want to lose weight. So I've been using these GLP-1s for a long time. I've been a top writer for GLP-1, and I don't even write it for diabetes. I've been just basically using off-label use for it. So, and anyway, so this was nicknamed the skinny pen. And I was like, oh my God, I wish I'd thought of that name. That would have been really cool. But anyway, it really got popular when movie stars and actors talked about it, but I was like way ahead of that. So I have this comprehensive approach. It's like, this is not the one-all. This is just to get you from here to there, just to jumpstart, and we will work on diet and lifestyle, and we're going to eventually get you off it. My intention is not for you to be on it for life. Although I have several women who love their wine and they don't want to exercise and they want to take this for the rest of their life, and they come in with I think there's a handgun in their purse, and they go, Dr. Lee, you're going to give me this. Okay. So anyways, FDA approved, and so semaglutide once a week, it can lower glucose and A1C. So this is basically for produced by the New England Journal of Medicine, the once a week, and they basically were using the 2.4 milligrams, and this was a double-blind trial, and they had a lot of patients, almost 2,000 patients, and basically they lost weight. So this got approved, and in that study they lost about 33 pounds, and so a huge amount of weight. And this is, anyway, 86% of the participants at least attained 5% weight loss. So this is semaglutide or Wegovy once a week. And how does it work? This is an interesting question. It's a unique pathway. And actually, there's some hunger centers in the brain, in the hypothalamic area. So basically, it stimulates the POMC and CART neuron in the hypothalamic area, which will basically decrease hunger, but it also inhibits two peptides that you can see up there, and basically, it increases satiety. So anyway, if you can decrease hunger and increase satiety, basically, you're going to cut down the appetite. Now, Elliot mentioned about the leptin. There are children know when to stop eating. If you have a child that cannot stop eating, they probably have a leptin deficiency. You know, children will just eat, and then stop, and they're full. But if these kids are basically eating, they're gaining weight and weight and weight and weight, they most likely have a leptin deficiency. And these GLP-1 has been a lifesaver for them because it's anyway, I don't deal with pediatric obesity, but I've heard many stories about it. So, as you know, if you write a lot of these GLP-1s, the common issue is nausea. And I use a lot of compounded semaglutide, and I'm very specific on how to use it. And I'll write, basically, I'll show you how I basically prescribe it. But if you start low and titrate up. And I had one woman who just like, to this day has blown my mind, because usually guys don't follow instructions. Usually, you tell them you start low and then go up each week. Usually they'll go up high and they go, I'm a man. And then they call in, oh, I'm so sick. But anyway, this one woman, she was late for work and she wanted to use the semaglutide, and she just didn't follow the instruction, and thank God she was overweight. She used she didn't use an insulin syringe, she used like this huge needle, and thank God she didn't perforate her bowel, and she dosed it 10 times higher than I would even recommend. She got so nauseous, she was puking like 70 times, and she didn't go to the emergency room. She's tough. She waited at my front door of my office till we opened, and she looked like she was dead. And I said, get in here. We're going to give you we're going to insert 4 intravenous lines in you. We gave her about 30 bags of fluid, and then her eyes like came up, and then when she was talking a million times a minute, it's like, okay, get out of here. And then 3 days later, she goes, I feel great. I lost a lot of weight. But that's not the way to do it. So if I don't tell this to my patients about this black box warning, I get the phone calls all day long. So I say, look, let me just tell you that semaglutide does not cause thyroid cancer, because somehow they get on the internet and they're going to call you. They go, Dr. Lee, you're giving me something that's going to cause me thyroid cancer. It's like, so I don't want that phone call. It's like, look, let me just give you like a 1-minute spiel on this. And the thing is that if you have a family history of medullary thyroid cancer, this is the rarest thyroid cancer out of all the thyroid cancers there are. You have papillary, you have follicular thyroid cancer, but all the way on the bottom is medullary. And medullary is usually genetic. And when I trained at University of Pittsburgh, we would see some families from West Virginia. And so if the cousins were marrying cousins, then that gene pool never really left. So I'm not quite sure about Puerto Rico if you have that issue. But anyway, the thing is that they dosed it, the FDA dosed it 100 times higher than you would dose it in humans, and they wanted to see what would happen. And in both species, mice and rats, increased these C cells. And we really don't have C cells in our thyroid. And they basically became overactive, and some turned into tumor and then cancer. So we don't really have C cells. We're not a mice. Genetically, we're not a rat, so except for attorneys. But anyway, so the thing is that if there's a family history of medullary thyroid cancer, I don't use GLP-1s on them. So anyway, here was a meta-analysis study, and also basically confirmed that too. So in conclusion, it's okay to use GLP-1, and it did not increase or decrease the risk of thyroid cancer, overactive thyroid, underactive thyroid, thyroiditis, thyroid mass, and goiter. So there is literature to support all this. All right, so there are some rare genetic disorders. So if you're into endocrine, you have MEN2A and 2B, which is a group of weird genetic disorders. But if you see pheochromocytoma, I've been looking for a de novo pheochromocytoma. in my practice for 25 years, I still have not picked one up yet, but anyway, I do screen for them. But anyway, this is super rare. So if there's this MEN2A, pheochromocytoma, and then the parathyroid adenoma and medullary thyroid cancer. But anyway, you'll probably never see that in your life. So this is how I dose it. If you use a compounded version, you have 5 milligrams in a 2 ml vial. So the concentration is 0.2 milligrams per ml. Start with an insulin syringe, 5 units, which is 0.25 milligrams once a week. And 99% of people will not get nauseous with this, except for my wife. She's so sensitive. So I have to, I used to have these pens and I would click it. So it was like, she would count the clicks and I would have to basically, I'm trying to bump it up, but she's washing dishes. She goes, I heard that, that's that. It's like, no. So I backed it down. So anyway, it's hard to get those Ozempic starter pens, but you can get it compounded and thank God there's compounded versions of it. So you can titrate 2 to 3 units each week, and then you can hit 20 units, which is 1 milligram. So I tell my patients start at 5 units, and then next week, if you have no nausea, 7 units, then 10 units, then 12 units, 15 units once a week, 17 units once a week, and then 20 units. Now, if you're losing weight at 10 units once a week, that's great. You don't have to basically go up to 20 units. I have a lot of people who are losing weight at basically 0.5 milligrams, which is 10 units once a week. Perfect. I mean, you're going to save money, you're going to use less of it, and this is phenomenal. So keep it refrigerated, and I always use it beyond. My wife always look at the canned fruits and they're saying, but it's beyond the expiration date, we got to throw it away. And it's like, no, it doesn't go bad, it's just it doesn't taste the best. But so I have a disagreement with my wife with labels. But anyway, the best use date, that's something you can, anyway, doesn't mean that's going to expire. So you can go beyond the best use date. I personally used it way beyond that too. So I tend to use semaglutide occasionally, and I may use it just for a month, once a year. And then get back to exercise. So anyway, it's one of those things that I've been on it myself. And anyway, I just love that it kind of just helps me. And then I'm addicted to sports. So anyway, I can get right back into it. So this is a compounded version of the higher dose, 2.4 milligrams. So you can basically use the previous one that I just showed you, up to 20 units. And then each week you can go by 5 extra units up to a dose of basically 48 units once a week, which is 2.4 milligrams. And you will get the similar dose of the Wegovy pen there. So let's talk about the King Kong peptide for weight loss, because there are going to be a few people, and I would say 95% of my patients lose weight with semaglutide at basically 1 milligram once a week. I have some patients have to go to 2, and then some people I have to go to the next one. So here's the King Kong for weight loss. It has GLP-1 with GIP, and basically it's the brand name is Mounjaro, and Tirzepatide is basically the compounded version name, and it's once a week injection. So it's not. I heard a speaker earlier today and said it's a wrong name for it, but it's glucose-dependent insulin-trophic polypeptide. Anyway, it's secreted also in the small intestines by the K cells, and it can stimulate the pancreas to release insulin. But what is the difference between GIP and GLP-1? When I was in fellowship at University of Pittsburgh for endocrine, we were studying this, and when this medicine came out, I go, it's not going to lose weight. I mean, GIP, I knew this 20 years ago or 15 years ago with the literature here. GIP basically does not suppress appetite. It increases fat cells. It slightly increases glucagon. And there's no effect of gastric emptying. Whereas GLP-1 is the thing that you want to use. So why is it that you combine a GIP with a GLP-1 and it causes more weight loss? And I was blown away. So May of 2022, the FDA approved Tirzepatide and for type 2 diabetes. Anyway, it's as of December 2022, it was not approved for weight loss. Still not approved. But what happens is GIP enhances the GLP-1 receptors. So the GLP-1 is more effective, which is like, oh, I get it. So it's not the GIP itself, but it's in terms of suppressing the hypothalamic area and causing early satiety or decreased appetite. It just helps the GLP-1 to work more efficiently. So anyway, this study basically says that they lost up to 25 pounds, and it comes in pens. So you do the 2.5 milligram once a week for 1 month, and then you go to the 5 milligrams once a week for 1 month, and 7.5 milligrams once a week for 1 month, and titrate up to 15 milligrams. I have some patients up to 15 milligrams, some patients 12.5, 10 milligrams, and they're basically doing well with it. Now, I would say if you're really sensitive to semaglutide with nausea, this is an alternative way to help with weight loss. And there's less nausea with this versus the pure semaglutide. So here's a compounded version, and sometimes they have B6 with it or some other vitamin to help maybe with nausea there. But you can look at the dosing here. But if I have a patient that has been on semaglutide, let's say 1 milligram once a week, had no problem with it, I don't want them to start at 2.5 and then titrate up because they have a wedding to go and they really want to lose weight. I will start about 7.5 or 10 milligrams and then go from there. So I'm comfortable with just moving it over rather than starting from the very beginning. So GLP-1 and GIP can reverse insulin resistance, and it breaks that cycle, and your insulin levels will drop. And in addition, you will, if you can exercise and do the lifestyle changes, you will do well there too. So, like I said, it's for short-term use, and you gotta basically work with your patient for lifestyle. I don't have a health coach. I wish I had a lot of help in my office, but I have to enter all the records and anyway, vital signs anyway. So I always tell my patients, look, let's see if we can cut back. You achieved your goal. Let's try it every other week, and then maybe try to reduce the dose too, and see how we do, and then maybe to stop it for 2 months. And see, and maybe we can keep going. And if necessary, if you feel like your weight's creeping up, okay, we can do it for a month and then eventually stop. And then maybe use it on a PRN basis, maybe 3 times a year you use it, maybe for the holidays, between November to January, you're just gonna gain weight, so let's start on there, and maybe the rest of the year you don't use it. So I'm okay, intermittent use, but not for long-term use, continuous. So here's some future drugs that are underway and they have clinical trials. So this one, the retatrutide, retatrutide, it's a triple G hormone receptor. I love that, triple G. So not triple D, but triple G. And it's a GLP-1, GIP, and glucagon. So could be interesting, but they've had a phase 2 study with 17.5% weight loss. And then there's an oral agent that's a non-peptide, but oral GLP-1, and they basically lost about 10%, and that's ORFOGLIPRON. And I hate these these names, because they're a tongue twister. So A summary with GLP-1. I think they're revolutionary when and I've been on a fast track in using them, early adopter, and been in love with it. And anyway, it does help lower insulin levels, reverse insulin resistance, and help with weight loss. Start low. This is key. Start low, titrate up. And there's no rush in trying to get to the maximum dose right away. And also, if they have family history of medullary thyroid cancer, don't use it. Now, there may be a family history of thyroid cancer, but most likely it's not medullary. It's most likely papillary or follicular. Anyway, let's talk about something else. This is a peptide, so I have some people who, Doc, I've tried everything, can't lose weight. So now I'm working on the mitochondria. Now, I do genomic testing. Elliot's more advanced than me, but in terms of genetic testing, but I'm learning a lot about it. But anyway, I just do this, and if they have the genetic defect, they lose weight. But if I didn't check the genetic defect, the bottom line is they want to lose weight. And so I use MOTS-C. This is a mitochondrial peptide, and we can measure MOTS-C levels. And as we age, guess what? It drops, like our GLP-1 levels. But MOTS-C can burn fat and give you more energy and lose weight. So who wants that? Just raise your hand. All right. It doesn't make you look younger, but anyway. So MOTS-C, they did this interesting study. They fed these rats a high-fat diet, and if they didn't have just all the rats would get fat. But if you gave MOTS-C with a high-fat diet, they basically kept their weight. So it prevented them to get overweight here. There's two types of fat. You have the visceral fat and subcutaneous fat. And the thing is that, let me go back up. Subcutaneous fat basically has a combination of brown and white fat. And when you're a baby, babies have a lot of brown fat and very little white fat, but as we age, we have more of the white fat and very little brown fat. What's interesting, when a baby is cold, it cannot shiver, but it can generate heat by burning the brown fat. So they have more brown fat on the chest and the face, and they can burn and generate heat. So if you can burn more brown fat, you will actually lose weight there. So there is something called browning of the white fat. So if you have a lot of white fat, as adults we do, you can convert it to brown fat. So it's called browning the white fat to brown. So MOTS-C can help in terms of turning on the brown fat and also browning the white fat. And so anyway, there's an interesting way it does it. And anyway, by giving MOTS-C, it can help with burning fat, and there is a protein called the uncoupling factor 1, and MOTS-C basically is involved with the uncoupling factor 1, so that the mitochondria in the brown fat can help burn fat. So here's a diagram of this, and there's uncoupling factor 1, and basically MOTS-C can interact with that, so it stops making ATP, but it actually helps with heat generation. So what's interesting is that there are a lot of bodybuilders that have been using peptides, and Lewis and I have been teaching peptides for over 5 years. And anyway, a lot of bodybuilders, they've like, oh yeah, I've done this before. But you can have a lot of interesting things with MOTS-C, but they use it to cut body fat there. So the recommended dosing of MOTS-C, it comes in a vial, and it comes in 10 milligrams per 5 ml vial. A common dose is 5 milligrams sub-Q 2 times a week. And some people may have like urticaria or a rash after injection. You have to stop that, but most people can tolerate it. I sometimes don't like the stinging of it. Some compound pharmacies make it really well so it doesn't burn. Others, it does burn, so I'm a little wuss in terms of burning because I've injected multiple times, so I prefer an IV push. And you get it intravenously, and I feel better. The first time I used MOTS-C, it's like, okay, I have energy, but I don't know, maybe placebo. Second time I tried it, it's like, all right, I definitely feel it. Third time, like, damn, this is good. And I swim a lot, so I swim usually in a 25-yard pool, and I was doing underwater breaststroke, like holding my breath, and I was like beating my personal records, like, damn, this is good. So I love it, MOTS-C. So what is the best exercise for weight loss? Raise your hand if you think it's running. Raise your hand if you think it's cycling, weightlifting, jumping rope, martial arts, swimming, pickleball. Anyway, so the thing is, your patient needs to find something that they need to enjoy, but the best way, I think, is they have to undergo a VO2 max test. We used to have this machine in my office, and you can basically calculate their anaerobic threshold. That's where your heart rate needs to achieve so that you start burning fat. But what is your anaerobic threshold? I don't know. We could guess. I can just throw out a number, but everyone's different. That's why you can get the test, figure it out. So once we had this, basically, you could do the VO2 max on a stationary bike, but let's say your anaerobic threshold is calculated to be 140. Then you do 5 intervals. Try to keep your heart rate for 30 seconds at about 140 and rest for 2 or 3 minutes, a repeat. Start with 3 times a week, and then eventually you can increase the intensity. I love to go like 3 minutes more, and I don't know, I just like that discomfort. If you want to take, anyway, you guys have all this on your slides here. In conclusion, you can start with GLP-1 to help with weight loss. If they don't tolerate it, you can move on to the GLP-1 with GIP, and you can also use MOTS-C to help. And I also use some product to increase NAD, because if you increase NAD levels, that's basically food for the mitochondria, and then the MOTS-C turns on the mitochondria to work faster, and you'll have more energy. And they can lose weight. So that's my talk. And exercise is the best. So make sure you always exercise. Okay, thank you very much.
Excuse me, doctor.
Yes.
Is MOTS-C a better long-term alternative for weight loss than semaglutide?
That's a good question. I would use semaglutide first in terms of for weight loss, because most people will lose weight with that. I use MOTS-C at the very end if they fail everything else, and that's kind of the way I do it.
But can you use it long-term?
Can you use it long-term? You should cycle MOTS-C. So generally you can use it for a month or two, take a month or two off, and then cycle it. Give your body a little break. But in the meantime, try to increase your NAD level. There is a lab that can measure NAD levels. And if your NAD level is like 20, you're going to be tired. So you got to get that NAD up by using a product called like NMN, not candy M&Ms, but NMN. And that's basically niacin derived, and that will increase your NAD level to help your mitochondria work better. So the mitochondrial peptides, I want to use it for, continuous long-term, I would just use it and cycle your MOTS-C. So, and in the advanced courses, we'll teach you other mitochondrial peptides. So, all right.
And just,
yes,
yeah, quick question and comment.
Sure.
Have you had, I know you usually use MOTS-C at the end. Have you had any patients where you actually have started concomitantly, the MOTS-C with the semaglutide, or I've done it with some cases, and I've.
Yeah, you could do it that way,
yeah.
but no, I generally,
at the end.
I just basically, it's like, they're gonna pay for semaglutide and it's cost, and it's like,
Sure.
okay, we'll do this later. I mean, if you have really deep pockets and they, it's like, okay, we'll do this.
All right.
But generally, I do one step at a time.
Sounds good.
Because if they get side effects, it's like 2 injections, is it, you know.
Hi. When you stop MOTS-C, what parameter you use in the future to follow up the patient, if it's only the weight or it's the energy, or when you sit and talk to the patient, what we are expecting on the long term?
Patients will say, I need a refill on it. They'll call my office and say, I want it.
Okay.
So I usually, when they feel it, you don't even have to talk about it. But I say, let's take a break. Let's, cycle. I mentioned that in the beginning. If you're starting to feel really good. There's also, we have to work on sleep quality, try to get the REM sleep up. There's a lot of variables in terms of fatigue. So MOTS-C is just one piece of the puzzle in terms of helping. All right. Oh,
One question, you
Sure.
had said that the GLP-1s paired with GIP, is there a GIP agonist that can be used in conjunction rather than the Tirzepatide, like the Semaglutide with a GIP agonist?
there have been in the diabetes world, they've been using GIP, but I'm not quite sure if they're commercially available. There were experiments in doing it. I just don't know any commercially available GIP, but interesting.
Yeah,
I know
that would
what
be a
you're
nice
thinking.
paired, yeah.
I know what you're thinking. Good. I like the way you think. Because it's expensive. Yes.
Good morning. How far along the long time of GLP-1 use? How many months or trials?
I'm happy within like 6 months to maybe 9 months, and then try to start titrating down. Some people need to be at 2 years before we start titrating down, but they have so much weight they have to lose. But generally, in my ballpark is 6 months to 9 months, and then I'll try to wean them and use it maybe occasionally.
Perfect, thank you.
Sure. And I think that's the key, because a lot of people, there's a lot of news out there that, loses muscle mass. Yes, as you lose weight, you lose things. But then we can talk about, hey, let's try to use some myostatin inhibitors, get your growth hormone up, and optimize your testosterone, build muscle, and all that. So, all right. Fantastic. All right. So,
Thank you.